Hello friends, today will be discussing a very important topic, that is the anti-rheumatoid drugs. These anti-rheumatoid drugs except corticosteroid, all the anti-rheumatoid drugs basically suppress the rheumatoid process, and that suppression of the rheumatoid process brings about the remission and retard the disease progression of rheumatoid arthritis. Also, one more thing is that these anti-rheumatoid drugs has no non-specific anti-inflammatory or analgesic action. They are used, as we know, in rheumatoid arthritis in addition to the patient who are already taking NSAIDs, that is non-steroidal anti-inflammatory drugs. They are used in addition. They are also referred to as disease modifying antirheumatic drugs or DMARDs, or sometimes they are also called as the slow acting antirheumatic drugs, that is saards. The benefit with the use of these antirheumatic drugs is seen within a few months of regular treatment. However, if we stop the therapy with these antirheumatic drugs, the relapse is also seen within a few months. For resistant cases of rheumatoid arthritis, we use the biological agents in the form of antibodies or other proteins we use for resistant cases of rheumatoid arthritis. Now here we will talk about the rheumatoid arthritis. So what is rheumatoid arthritis? Rheumatoid arthritis is basically an autoimmune disease in which we see there is joint inflammation and there is synovial proliferation and destruction of the articular cartilage. And we know in rheumatoid arthritis there is production of immune complexes which are IgM activated complement. These immune complexes secretes lots of tumor necrosis factor alpha and interleukin 1, and these tumor necrosis factor alpha and interleukin 1 is chemoprotected for the neutrophils. Also, there is lot of inflammatory cells involved in rheumatoid arthritis that secretes lots of lysosomal enzymes. These lysosomal enzymes indirectly damages our cartilage and erodes the bone. Also, prostaglandin is also secreted in the process, and that leads to the vasodilation and pain in the joints. And we know that rheumatoid arthritis is a chronic progressive crippling disorder with waxing and waning course. For the treatment of rheumatoid arthritis, the first line drugs is the non-steroidal anti-inflammatory drugs. These are the first line drugs, and these drugs basically reduces the pain, swelling, morning stiffness, and immobility associated with rheumatoid arthritis. However, these non-steroidal anti-inflammatory drugs does not arrest the disease process. So, what is the goal of the therapy of rheumatoid arthritis? The goal of therapy in rheumatoid arthritis is we have to reduce their pain, swelling, and joint stiffness, prevent the articular cartilage damage and bony erosions, prevent the joint deformity, and we have to preserve the joint function also. For mild and early cases of rheumatoid arthritis, they are mostly treated previously with non-steroidal anti-inflammatory drugs only. But current recommendation is to add the DMARDs as soon as the diagnosis of rheumatoid arthritis is confirmed. For mild cases of rheumatoid arthritis, for using the DMARDs, we have to see the risk-benefit ratio, as the adverse drug reaction which are seen with these anti-rheumatoid drugs may be very serious, so we have to see their risk-benefit ratio before using DMARDs for mild cases. Currently, we use more than 2 DMARDs for rheumatoid arthritis. For advanced cases of rheumatoid arthritis, we have to add 2 or 3 drugs together. And we know, as we know, the DMARDs lose effectiveness over time. Now we will see the classification of the anti-rheumatoid drugs. They are classified as DMARDs, that is the disease-modifying anti-rheumatic drugs, and adjuvant drugs. In the adjuvant drugs, we have the prednisolone and other drugs, and gold and penicillamine are also adjuvant drugs, but they are obsolete nowadays. And among the DMARDs are further classified as non-biological and biological agents. The biological agents are also include the tumor necrosis factor alpha inhibitors, that includes our etanercept, infliximab, and adalimumab, and interleukin 1 antagonist, that includes the anakinra. Among the non-biological agents, we have the immunosuppressants, that is includes the methotrexate, azathioprine, and cyclosporine. Also, sulfasalazine, chloroquine, hydroxychloroquine, and leflunomide are the non-biological agents we have. Let's first discuss about the non-biological agents. These include the immunosuppressants, that is our methotrexates. So, the methotrexate, the mechanism of action, it inhibits the dihydrofolate reductase enzyme, and it has prominent immunosuppressant and anti-inflammatory action. The beneficial effects in rheumatoid arthritis is due to inhibition of the cytokine production by methotrexate. It also inhibits the chemotaxis, and cell-mediated immune reactions are also inhibited by the methotrexate. When used in lower dose, it has improved acceptability, and the dose is 7.5 to 15 milligram weekly of methotrexate. Methotrexate has rapid symptomatic relief in patients of rheumatoid arthritis within 4 to 6 weeks. So it is preferred for initial treatment of rheumatoid arthritis. It is also the first choice drug or first choice DMARD, that is methotrexate is the first choice DMARD which we use. So it is the standard treatment for most cases of rheumatoid arthritis, that also includes the juvenile rheumatoid arthritis. The response with rheumatoid arthritis is more predictable and sustained over long-term use. Combination regimes which we use in rheumatoid arthritis of 2 to 3 drugs, that also includes our methotrexate. The oral bioavailability of methotrexate is variable, and that can be affected by the food also. In renal diseases, since it is excreted through renal route, it is not recommended to use in renal disease. Probenecid and aspirin increases the level of methotrexate in the blood, so we have to avoid using probenecid and aspirin with methotrexate. With trimethoprim, since trimethoprim also inhibit the dihydrofolate reductase, methotrexate also inhibit these enzymes that can depress the bone marrow, so we have to be careful in such cases. The side effects with low dose regime is oral ulceration and GIT upset. For prolonged therapy with methotrexate, there is risk of liver damage which can progress to cirrhosis. Methotrexate also increases the risk of chest infection. The contraindication with the use of methotrexate include pregnancy, breastfeeding, liver disease, active infection, leukopenia, and peptic ulcer disease.